Hello, this is Joseph Miles, and this is my presentation on hope and achievement for depressed adolescents. I am a pharmacist and I am a master's candidate for Biomedical and Health Informatics. And I was drawn to this topic because as a pharmacist, I've dispensed a lot of medications to help children and adolescents with various mental conditions, and sometimes it's unclear whether or not we are trying to get rid of negative effects or if we have a positive outlook on the future and we are working towards the betterment of the child or adolescent. So this is my proposal for a study to evaluate some of the positive effects of helping adolescents. Specifically, in this case, we're talking about adolescents that are dealing with moderate to severe depression. A little introduction. When we treat depression, are we attempting to make negative symptoms go away, or are we trying to improve the patient's overall condition? Again, that is the question that I ask as a pharmacist. That are we just taking all emotion away from a child and leaving them a blank canvas, or are they actually getting to a place where they are better able to overcome obstacles and achieve goals? So what we have found in previous literature is that hopelessness does equate to poor outcomes in treating depression. That is a known, that seems to be pretty well validated. But a lack of hopelessness does not equal having hope. And hope does not equal intelligence. But what we do see is that adolescents and children that are high in hope, that they do perform better in school, and that's across all subject levels, with science and arts and language. We do find that correlation between hope and achieving better results in school. Also, parallel to this, we have the Healthy People 2020 initiative, and that's overseen by the Office of Disease Prevention and Health Promotion. And I have a web address there, and down the bottom of the slide I have a little snippet from that web address, and what this states, based on their evaluation, 68.9% of children with mental disease received treatment in 2008. And I'm not entirely sure how they came up with that number. I tried to look into where that number came from. Obviously, there's going to be some estimation involved in reaching that number. But regardless of how they came to that conclusion, if the real number is anywhere near that, that's a pretty startling result. And one of their leading health indicators, that's what that LHI means. So in other words, one of the most important things that they consider as far as a goal to achieve by the year 2020 is to reduce the proportion of adolescents who experience major depressive episodes. So the specific aims of this proposal would be that youth treatment research needs to examine intervention impact in ways that go beyond assessment of the specifically targeted youth symptoms and diagnosis. And that's a direct quote from Wise, Doss, and Hawley in that 2005 article I have referenced there, and the references are at the end of the slides. So in this study, we'd like to explore correlations between depression treatment, hope, and achievement. So hopefully what we'll find is a negative correlation where depression symptoms go down as hope increases. We're hoping to find a correlation that as hope increases, achievement increases, as I had mentioned in one of the earlier slides, that it has been observed in previous studies. And a decrease in depression symptoms then can correlate with increased achievement. Again, we're talking about correlations here. Causality is not really necessarily important to that part of the analysis. what we want to prove is this correlation, to find that in fact treating and controlling these depression symptoms does increase hope and does increase the adolescent's ability to achieve. As part of this, what I would also like to propose is that we can explore the effect of pharmacotherapy versus placebo. It seems in previous studies that an active treatment, even if it is placebo, does seem to have positive effect as far as outcomes. So I would like to work in a little of this comparison to see if under a blinded condition, if that stands true as far as our measurements of hope and achievement. So the null hypothesis for this project would be that treating depression will have no effect on hope nor achievement. And the alternative hypothesis that we're trying to prove is that treating depression in adolescents will improve a measure of hope as compared to baseline, and that an increase in hope will correlate with an improvement in academic achievement scores. Our experimental design. I decided to pick a window of 12 to 15 years old, particularly for the development that would happen for a child in those years and the importance for them to keep up with their peers, not fall behind. And I would prefer if the subjects were referred by physicians or clinicians. I noticed that in my evaluation of previous studies that that's not always the case, so it's a little ambiguous as to where the diagnosis of depression is coming from. We are hoping that the diagnosis would come from the physician and clinician, and that it would be a moderate to severe depression, because only under those conditions would it be justified to really consider adding medication or placebo. So then from that point we can randomize equal numbers of adolescents between medication and placebo. And then as a control group comparison, we would also like to recruit an equal sized group of unaffected adolescents that are not affected by depression. And one of the screening tests that we will do, that you see a few lines down on the slide, is the test for test depression symptomology, the Children's Depression Inventory. And a score of 17 or higher in previous studies does correlate with depression. So this would be a sort of a second validation to make sure that, first of all, our control group is free of depression symptoms at baseline, and to a degree to make sure that the adolescents that we are performing treatments on do necessitate those treatments, because no treatment comes without risk. So we want to make sure that we're not exposing anybody to undue risk. So baseline demographics are pretty important in mental health. It seems like we suffer a little bit from a historical lack of gathering information on age, gender, ethnicity, geographic location, and socioeconomic status. So sometimes it's hard to really use the results from older studies, because we're not entirely sure which population they apply to, because these factors can affect outcome. There are some studies out there that will show maybe specifically that gender doesn't affect a certain aspect of mental health. But we can't make those assessments until we actually record this information at baseline, so we can do comparisons with a segment of the population that matches our sample. Part of the baseline assessment would be a test for verbal intelligence. The WISC test, which is one of the Wechsler exams, does correlate to IQ. So if the results of that test would show that the adolescent has likely an IQ less than 80, they may not be able to accurately answer the questions that we have on these other tests, and so that would exempt them from the trial. So as I already mentioned, we'll test depression symptomology, and then the test for hope and achievement I have listed there for the Child Hope Scale and the Wechsler Individual Achievement Test. And so those are the tests that we would perform at baseline. Just to give you a feeling of what the Child Hope Scale looks like. It's a pretty simple test, because as you'll see later, I do have in my proposal that this test will be given 3 times over the course of 12 weeks. And part of the reason I state that is because it is an easy enough test, just 6 questions, and it's worded easily enough that an adolescent between the ages of 12 and 15 should be able to easily and accurately answer these questions. And this test has been validated several times in the article that I referenced in the bottom, the Snyder et al. 1997. There are several validations within that study, and then there are others that have been performed since then. So it's an easy test, and it seems to be very accurate at what it does. So the experimental timeline, as I mentioned, the time 0 is the baseline, and then the halfway point that I mentioned for the retest of hope, it would be at 42 days, and we'd call that time 1. And the end of the study would be after 12 weeks, 84 days, that would be time 2. And at the end of the study, we would retest depression symptoms for our 2 treatment groups that receive therapy plus placebo or cognitive therapy plus medication. And of course, we will retest hope for a 3rd time, and then a 2nd assessment of achievement. And again, there is the control group. So if there's a change in achievement in control as well, we can see that it may or may not be attributed solely to the treatment of depression. It just might be something that happened over the course of the 12 weeks, and hopefully our control group will be representative of the same type of population as our trial group. As far as the plan for data analysis, we would keep track of all of the information in Microsoft Excel, and using the real statistics package in Excel, we can perform some repeated measure ANOVA to compare time 0 to time 2 for depression treatments, time 0, 1, and 2 for hope, and time 0 and time 2 for achievement. We can do a one-way ANOVA test then to compare our treatment groups with the control group, like I mentioned on the last slide. And then, as I had mentioned earlier, also the coefficient of determination and correlation coefficient will help us determine to what degree treating depression is, how hope is affected by the treatments of depression, how achievement is affected by hope, and also you have the A implies B, B implies C. So we have A implies C depression treatment affecting achievement, and we will get measurements for all 3 of those. So for a power estimation, the mean change on previous studies in hope after an intervention seemed to be approximately 1.2 points. So based on that, that is approximately what I would expect. It's hard to state anything about clinical significance of hope because there is not a lot of information out there currently that I could find that correlates a number on a hope scale with clinical effect. So hopefully a study like this would open that door to help us to start being able to measure hope. As I mentioned earlier, there's hopelessness, and the lack of hopelessness does affect the outcomes for a depressed adolescent. But we're specifically looking at a hope scale in this study. Standard deviations through several trials seem to range from 3.01 to 6.11. So using the most conservative, instead of taking an average of those, since the standard deviation can affect the power of the study greatly, I used a calculation going with the highest standard deviation of 6.11. I did power it at 80%. I will talk about that a little bit later, using the alpha for the type 1 error of 0.05 and using that effect size of 1.2. And using those numbers, the calculation came out to be 67 subjects per group. Studies like this do seem to have a great deal of loss to follow-up. A conservative assessment of that would be 20% possible loss to follow-up. So using that number, we come to the final conclusion that 84 subjects should be recruited per group, or 252 individuals total. Again, that would be 168 subjects that receive treatment, and then the other 84 would just be our control group that will just be taking the tests that we can compare to our treatment groups. From there, using those numbers just to cross-check and make sure that our numbers for achievement make sense at the 80% power. If we go with the assumption that we can retain at least 67 subjects at an 80% power, that our study should be able to detect a difference of 6.78 points on the achievement test. Based on previous results on these achievement tests, it seemed like a number to expect at baseline would be somewhere around 93 on the Wyatt exam, and a population average is supposed to be 100. And so going with the assumption that the children in the adolescents in our population will be representative of average students, we would expect that number to approach that 100 level. Again, there's a lot of assumptions going on as far as assuming that our baseline will be 93, but because our test should be able to find that 7-point difference, I am comfortable with staying with the 84 subjects per group total, and hopefully we can retain more than the 80% of that group, and increase power to find a difference. Again, this study is more looking towards correlation, in my opinion, because to put clinical significance on these changes of 7 points on achievement and 1.2 points on hope is kind of a little bit ambiguous. So any change that we would be able to detect would be great, and hopefully we'd be able to find a significant correlation between the changes that we measure. So again, expected outcomes as far as problems, as I discussed, the loss to follow-up, and I'm factoring in that extra 20% so that we would be able to simply eliminate the loss to follow-up. I would like to track why we lost individuals to follow-up, because we may be able to make some assumptions as to what that could have done to our end results. But to keep the results pure, I would like to initially look at the results without the lost subjects, and only do the statistics on the completed subjects. The expectation is that depression symptoms will decrease. There have been many studies conducted between 8 and 12 weeks using similar treatment modalities as we are in this study. and they consistently will find results. And that's not the primary outcome of this. This is, again, the correlation. We want to correlate with the depression symptoms. We're not trying to prove a treatment of depression. And based on previous results, we would expect hope to increase. To what level, we're not sure. Again, to assign significance to that change is a little bit ambiguous at this point. And there is a question mark as to whether or not placebo or medication will be any better at helping hope to increase. And that same discussion goes for achievement. We don't know what the significance is from the numbers that I mentioned in the previous slide. To expect an average mean of 93 at baseline, a normal result on the Wyatt achievement exam is considered 90 to 109. So 93 would be within the normal range. So what's the clinical significance of raising that number from one normal level to another normal? That is up for interpretation, and we'd have to wait and see what the numbers say. But again, the goal of this study is to find that correlation, that we are indeed helping positive attributes of an adolescent by treating their depression. I'd mentioned that I would come back to the 80% power from the Tavernier and Girardot. They did do a meta-analysis of similar studies, and they found that studies that intended an 80% power did have results that resulted in a 23% chance of being underpowered. So that would be a real risk of this treatment, of this proposition. But again, I don't see that as a critical problem, because if we don't get the effect size that I calculated, I believe that we could still find significant results that we would be able to discuss, and hopefully this would open doors to looking at these positive outcomes of treating depression. And the last line is just reiterating what I've said several times. So even though the 23% chance is real for underpowered, the hope is we'll still find changes, and we'll still be able to find correlation between those changes, and to be able to say clinically that that we have diminished the negative effects of depression, but rather than just eliminating a negative, we can start to look at positive outcomes that these adolescents are going to be better able to achieve success academically and socially. So to close this out with a little bit more discussion and commentary on the background behind this, we are looking at an adolescent population, and as an adult, I know that I've developed a lot of coping skills throughout my life, and when you're 12, 13, 14, 15 years old, you don't have those life experiences. So when something comes up in your life, like a major depressive episode, the coping mechanism is not fully intact, and something that would be debilitating as an adult. And if you noticed in that slide that I had earlier, from the Healthy People 2020, they do mention adolescents and they do mention adults as far as major depressive episodes. So this is a concern at all age levels, but the outcome of a major depressive episode in adolescence can be extremely bad, because there's so much development that happens in that individual, socially, and academically at those ages of 12, 13, 14, 15, that it would be really nice to know that by helping that individual through these episodes, we are not simply to overstate it, I guess, to make them a zombie and just not care about anything, that we are actually giving them tools to help them to achieve. And again, so that's the new focus that I would hope that a study like this would bring towards the positive effects of treatment versus the decreasing negative effects. As I was looking at this, actually one of my inspirations for looking at this is work that I've been doing with the National Institute of Mental Health and their research domain criteria, the RDoC. I have the website listed there, and one of the things that really struck me as I was looking at these positive constructs like hope and achievement was how poorly representative they are in this research matrix. And I'm going to pull that up here to just kind of make a case in point that these are the various RDoC units of analysis, and they list these all self-report. And when you click on one, and we'll just randomly pick this childhood trauma questionnaire, it will give a little bit of information about it, and it'll tell you what domains that this is associated with, and which construct within that domain these separate elements are associated with. And through here and read about, reports apply. Well, sleep wakefulness under the arousal and regulatory system domain. But you won't find is a measure of hope. They do have hopelessness, which makes sense from the previous research that has been done that shows that a high level of hopelessness bodes very poorly as far as a predictor of outcomes for depressed adolescents. However, when you click on hopelessness, you get absolutely no correlation with any construct or any valence system under the RDoC matrix. So even though there is a lot of history of testing hopelessness, a lot of the references that I have for this presentation are 20 years old. It seems as though it's still not on the radar of something to keep track of. So hopefully a study like this, regardless of significance statistically of results, would increase awareness of this issue, or more accurately renew awareness, since this has been ongoing for 20 years, various studies that exist, and I have some of them referenced on the following slide, but that's not the complete list of references. I may in the future have a link to more references that I've used as far as the complete proposal for this study. So to close this discussion, I have another quote here, and it is, "If youth are to be successful in an ever-increasing competitive global environment, it is essential that their academic achievements reflect their innate ability." To me, what this says is that adolescents have the ability to succeed. An event like a major depressive episode does hold a youth back. It has been shown to result in lower achievement scores, and This study is very much to the heart that by helping adolescents through these major depressive episodes, we do give that youth the capability to succeed, especially as things become increasingly competitive. And hopefully there will be increased awareness as to the importance of this. Again, the references that I've used just for these slides are here. And this is the heart of a lot of the research that I did. Again, there's several fold more of these references in my overall report. And if there are any questions or comments that you'd like to make on this presentation, my email address is jmiles3, that's jmiles3 @oswego.edu. Thank you very much for watching this presentation. Take care.